Hello, I'm Brian Prescott with PCCA. I'm here with Dr. Brian Futrell, a wound specialist, and we're here to talk about some venous ulcers. Dr. Futrell, why don't we educate our audience a little bit on what a venous ulcer is?
In a venous wound, you have interstitial pressures, or pressures within the vein system, pushing out into the extrastitial, or the flesh, right, out into the skin and the soft tissue, creating an imbalance in the chemical processes that are going on in the wound environment. And one is sometimes they're created by direct stretching of the wound, and sometimes that process is right at its max, and you get a small injury that creates this large or open wound.
Whenever we're maintaining a venous ulcer, circulation generally isn't that big a problem, right? So I may not need to use the stimulate, like nifedipine, for example, for that area to increase circulation, because circulation generally is not a problem. But of course, we're going to maintain antibacterial, maybe we can put some wound healing. But compression, I hear compression is a huge part of venous ulcers.
Correct. Without compression, you're going to fail, right? And I see this a lot. Unfortunately, a lot of times I see the right products being applied to the wound without compression or without pump therapy, or oftentimes my wound or vascular specialist can go in and they can sclerose a contributing vein, right, coming up into the area of the wound. And if they can go underneath that wound and actually block that vein, suddenly that local venous hypertension, all right, or increased fluid pressure delineates or diminishes, and the wound goes away or resolves, right? So there's very much a balance there, but you have to manage that venous hypertension, and standard therapy is a compression wrap. At least in my hands and in my office.
With venous ulcers, you're obviously putting on a compression wrap. How long is that thing staying in place usually?
5 to 7 days. Okay,
right.
At least 3 days, but typically 5 to 7 days.
All right. Generally, these wound care formulas, regardless of what we're putting into, once a day, twice a day therapy is usually fine. But whenever you're dealing with a patient with a venous ulcer, you want to make sure you go in there and tell the doctor, look, we realize that we're only going to be doing dressing changes once a week, twice a week, maybe?
At most, that's right.
Right.
That's right.
So do you find these wounds to be wet, dry, a mixture of each? What is more common?
Venous wounds are typically a very wet wound, highly exudative or draining. They often have an odor. They can be complicated by Pseudomonas. And so this is where you have to kind of mold the art and the science of wound care. You have these great products that PCCA can represent, but if you're not doing compression, if you're not managing the fluid, if you're not doing elevation, you're going to really fail ultimately. And so that's where the art, the science really gets fun and interesting.
Well, thank you, Dr. Futrell, for taking the time to educate me more on venous ulcers. Is there anything else you wanted to share with our audience?
Well, there's always a takeaway point, right? It's something we really want you to hone in on. And with venous wounds, it's a collaboration with a vascular specialist and a wound care specialist. And it's also about nutrition and compression. Compression, compression, compression. Thanks so much.